Stomach and duodenum. Functions of the stomach: grinding and mixing food into homogeneous chyme, food reservoir allowing small passage of chyme into the duodenum, early stages of protein digestion by pepsin, secretion of intrinsic factor, which is essential for vitamin B12 absorption, secretion of hydrochloric acid, which activates proteolytic enzymes such as pepsin, kills bacteria in swallowed food, facilitates iron absorption. There is balance between the attacking forces, acid and pepsin, and the defense mechanism, such as mucosal barrier. Rising in the acid secretion or weakness in this barrier leads to starting of peptic ulceration. Motility. The process of receptive relaxation is complementary to the storage function in which the body and fundus of the stomach relax to accommodate increasing food volume without pressure increase. Gastric motility is a function of the intrinsic nerve plexus, but is modified by the autonomic innervation and the content of food. The parasympathetic system encourages gastric emptying, division of the two vagal trunks, induces gastric stasis, and inhibits receptive relaxation. The sympathetic system leads to inhibition of the motility. Solid, fatty, and hyperosmolar foods retard gastric emptying. Hydrochloric acid secretion in response to eating. 3 phases: cephalic phase, gastric phase, and intestinal phase. Cephalic phase mediated by vagal stimulation, which leads to direct effect on parietal cells, leading to acid secretion, inducing gastrin release from the G cells of the antrum, provoked by the sight, smell, and thought of food. Gastric phase mediated by hormone gastrin, which is the most powerful stimulator of gastric acid secretion, food and products of early protein digestion, mechanical distension of the antrum, gastrin release from the antrum mucosa into the bloodstream. Low pH, less than 2, high acidity, inhibits gastrin release by negative feedback. Gastrin acts on the parietal cells through the release of histamine. Intestinal phase, the least contribution. The involved factors are poorly understood. Gastroduodenal mucosal barrier protects mucosa from being digested by acid and pepsin. Include mucus secreted by the mucosa, protective lining, bicarbonate secretion by the mucosa present between it and the protecting layer made of mucus. The surface pH is higher than the luminal pH. Rapid regeneration of mucosal cells, abundant mucosal blood flow, prostaglandins which maintain blood supply, factors which weaken gastroduodenal mucosal barrier, drugs such as aspirin and NSAIDs, antiprostaglandin effect, duodenogastric reflux of bile, Helicobacter pylori infection, secretion of urease enzyme which liberates ammonia and increases gastrin, proteases which destroy the mucus. Acute gastric dilatation. Definition: stomach loses its tone and rapidly dilates to enormous size, sometimes filling the abdominal cavity to an extent that other viscera are totally obstructed. Pathogenesis: the stomach becomes filled with air, dark and foul fluid. The source of the fluid is mainly from the intravascular compartment, which is depleted and the patient passes into hypovolemic shock. The basic pathological features cannot be easily explained but can often be prevented. There's a lot of similarities between acute gastric dilatation and paralytic ileus. Both occur post-operatively, caused by GI atony, preventable, vomiting and distension, same treatment, drip and suck, IV fluid drip to correct deficits and provide needs with nasogastric suction. Etiology of acute gastric dilatation: it can occur post-operatively, especially after pelvic operations, splenectomy, cholecystectomy, gastric surgery, which is rare, during labor, few cases, in patients immobilized in plaster casts, and in patients suffering from debilitating or toxemic states as terminal events. Clinical picture: early cases and neglected cases. Early cases: hiccup, upper abdominal discomfort, tachycardia, should be diagnosed at this stage and do gastric decompression by nasogastric tube. Neglected cases: effortless vomiting of dark foul-smelling fluid, picture of hypovolemic shock, upper abdominal distension, succession splash, aspiration pneumonia may occur. Prevention: placement of nasogastric tube after major abdominal surgery. Treatment: insertion of nasogastric tube and continuous aspiration. Attention to fluid, electrolytes, and acid-base balance. Acute peptic ulcer. Types: multiple erosions and true stress ulcers. Multiple erosions: site in the body and fundus of the stomach. Causes: patients receiving NSAIDs. Being antiprostaglandins, they weaken the mucosal barrier. Number and shape, they are multiple, shallow, and punched out. Size from 1 millimeter erosions to 1 centimeter or more. Depth, usually limited to the mucosa and the submucosa. Outcome, after healing, there is no evidence of scarring. Clinically, they present as indigestion and difficult to recognize at this stage, only recognized when they bleed as it need urgent upper endoscopy. True stress ulcers, pathology, multiple erosions, if not promptly recognized and treated, they coalesce to become acute hemorrhagic gastritis, leading to severe and intractable upper gastrointestinal hemorrhage. Causes, ICU patients, severe trauma, major burns, Curling's ulcer, severe acute pancreatitis, shock, especially septic shock. Pathogenesis, uncertain, but they represent as failure of the gastric mucosal barrier, whether due to vascular injury with ischemia of the mucosa, reflux of bile into the stomach, hydrogen ions bag diffuse the mucous membrane. Investigations by endoscopy, barium meal is contraindicated. Peptic ulcer disease, its nature, it's caused by acid pepsin digestion of mucous membranes and only occur when there is functioning gastric mucosa capable of secreting both acid and pepsin. Sites, acid pepsin secreting mucosa doesn't digest itself, but it will do so to adjacent mucous membranes of the following sites: duodenum, the commonest, alkaline gastric antrum, jejunum after gastrojejunostomy, lower esophagus, small intestines adjacent to mucous diverticulum containing ectopic gastric mucosa. Treatment, prophylactic treatment and actual treatment. Prophylactic treatment, patients at high risk of developing stress ulcers should receive both proton pump inhibitors or H2 blockers. Intraluminal antacids and sucralfate may be used. Actual treatment, discontinuation of the offending drug, if there is any, correction of the shock state, PPIs as omeprazole or H2 blocking agents given orally or IV according to the severity, intraluminal antacid maintaining intraluminal pH of at least 5, mucosal protectors as sucralfate. Severe bleeding requires controlling blood loss by endoscopy, whether by adrenaline injection into the submucosa or laser coagulation. Blood transfusion. If all previous measures fail, urgent gastrectomy. You should know that sucralfate acts locally and preferred in pregnancy because it's not absorbed like PPIs. Chronic duodenal ulcer, etiology, multiple factors. It's associated with increased gastric acidity. Helicobacter pylori, NSAIDs, diseases associated with increased gastrin production, genetic predisposition, and increased vagal tone. Helicobacter pylori, found in the mucosa of 85% of duodenal and 75% of gastric ulcer, produces urease enzyme which transforms urea to ammonia. Alkalinity of the antrum, increased production of gastrin. NSAIDs, they inhibit prostaglandins, decreasing the mucosal blood flow, and they also inhibit proliferation of mucosal cells, leading to prevention of healing. Diseases associated with increased gastrin production, Zoringer-Ellison syndrome, which is a rare condition, whether by pancreatic tumor secreting excessive gastrin hormone, or hyperplasia of G cells in the antrum, which is less common. Hyperparathyroidism, unusual cause, high calcium level stimulating excessive gastric production. Genetic predisposition, acting by production of large parietal cell mass, double the normal. Increased vagal tone, maximum at night, evidenced by increased amounts of overnight gastric acid production. Eradication of H. pylori from the stomach reduces the recurrence rate following medical treatment. The high gastrin level leads to marked elevation of the HCl production. Smoking will most probably not cause an ulcer, but it may delay its healing. Active ulcer is associated with marked induration surrounding it, mistaken for malignant disease. Pathology, gross appearance, size, usually small, site in the first part of the duodenum, on the posterior wall, more common, on the anterior wall, less common. Sometimes two ulcers occur, one on the anterior wall and the other on the posterior wall, and is called kissing ulcers. Consistency in duration, repeated healing attempts, excessive fibrosis, gross duodenal deformity, seen at operation and inferior duodenal radiographs, edge, sloping edge, floor, covered by thin layer of granulation tissue, base, usually lying in the muscle coat, or may even exceed to lie in the pancreas. Complications: perforation in anterior ulcers, bleeding in posterior ulcers because of their close proximity to the gastroduodenal artery and its branches, pyloric gastric outlet obstruction due to dense fibrosis. Clinical picture: in young active persons, appear well-fed and plump. Symptoms: pain, the leading symptom. Site: deeply seated in the epigastrium. Type: described as boring. Time: few hours after meals, hunger pain. Undiluted gastric acid passes to the duodenum, irritating the ulcer, producing pain, usually occurring at night, characteristic of duodenal ulcer. Relieved by food and by antacids. Patients carry them with them biscuits so that they consume it when the pain comes. Nausea and vomiting, not prominent features of uncomplicated ulcers. Periodicity: pain occurs during periods of activity of the ulcer, variable length, but usually lasting for a few weeks, followed by period of quiescence, lasting for a few months, during which the patients are quite healthy. Clinical picture of complications may be the first presentation: anemia with easy fatigability and pallor due to chronic bleeding, melena and/or hematemesis with shock due to acute bleeding, repeated vomiting due to pyloric stenosis, sudden severe pain of peritonitis when ulcer perforates, pain referred to the back, meaning penetration of the pancreas. Signs: localized epigastric tenderness may be present. Duodenal cap is normally triangular in the X-ray. You should know this. So we're going to talk about investigations. Endoscopy: the best investigation. Done in all patients suffering from typical ulcer dyspepsia. The ulcer is directly visualized. Advantage: no radiation. Barium meal, second place after endoscopy. Normal duodenal cap appears as a smooth triangle. The ulcer itself may show as small barium spot which remain inside the ulcer, crater after the passage of barium, fixed pouching of the duodenal cap, or fixed deformity, trefoil, if fibrosis occur. To detect Helicobacter pylori, culture from biopsy material more commonly, or serology or breath test. Treatment: medical treatment. The main treatment of uncomplicated cases is medical. The aim: to reduce acidity to heal the ulcer and to maintain it healed. Medications: PPIs, proton pump inhibitors, H2 receptors blockers, eradication of Helicobacter pylori. PPIs, examples: oral omeprazole, 20 mg per day, and lansoprazole. Mechanism: markedly reduction of gastric acidity in a matter of days. IV omeprazole is used in emergencies. H2 receptors blockers, examples: cimetidine, ranitidine, and famotidine. Mechanism: reducing gastric acid production. The usual dose of oral ranitidine is 150 mg twice daily. Eradication of Helicobacter pylori. Eradication reduces the recurrence rate. Triple drug therapy consisting of metronidazole, tetracycline or amoxicillin, plus bismuth compounds. Given for 2 weeks, excellent eradication in 90% of cases. Testing for Helicobacter repeated 4 weeks after stopping treatment. Vagus is responsible for nervous phase of gastric acid secretion. This is a note. And another note: NSAIDs are prohibited. Endoscopy is repeated after 6 weeks of medical treatment to evaluate healing. If ulcer healed, full dosage treatment is continued for a few more weeks. The main disadvantage of medical treatment is that once the drugs are stopped, high rate of symptoms of recurrence occur. Surgical treatment: it's mainly indicated for complicated cases. Elective surgery is indicated for failure of medical treatment to control symptoms, relapses after repeated attempts to adequate medical treatment, duodenal ulcer presenting by fibrotic pyloric stenosis, complicated peptic ulcer, perforation, bleeding, or obstruction. Aim of the surgery: healing the ulcer and adequate protection against recurrence. The principle of surgery: vagotomy, permanent and adequate reduction of gastric acid secretion, which may be truncal vagotomy and drainage, or highly selective vagotomy. Truncal vagotomy and drainage: the trunks of the vagus nerves are exposed and cut, leading to stomach denervation, abolishing gastric acid secretion immediately by 80%, decreasing to 50% or less by time, not compromising surgery results. Recurrence rate 5 to 10%. Denervation of the antrum leads to gastric stasis, so drainage procedure is needed, such as gastrojejunectomy or pyloroplasty. Gastrojejunectomy, creating stoma between dependent part of the stomach and proximal jejunum. Pyloroplasty, destroying pyloric sphincter by cutting it longitudinally, then sutured transversely. highly selective vagotomy, denervating only the body and fundus of the stomach, the acid-secreting parts, leaving pylorus and its antrum fully innervated, preserving gastric emptying, no need for drainage procedure, ligate all branches of the left gastric artery to the stomach because the secretory fibers run in close association with them, stopping short of the branches of the antrum, and it's called crow's foot. Chronic gastric ulcer types, type 1, 2, and 3. 1. Occurring in the body of the stomach on the lesser curvature, 60%, preceded by gastritis, which causes damage to the gastric mucosal barrier, not caused by high acid production. Patients have lower than normal acid secretion. Type 2 occurs in association with duodenal ulcer, 20%. The duodenal ulcer develops first, inducing duodenal deformity and gastric stasis, which leads to gastric ulcer. Type 3 occurs in the antrum or pyloric canal, 20%. Type 2 and 3 are associated with gastric hypersecretion and have the same etiology as duodenal ulcers. Incidence less prevalent than duodenal ulcers, in males more than females, by smaller margin than in duodenal ulcer. Gastric ulcer occurs at older age than duodenal ulcers. Exceptions may occur. Ulcer situated away from the lesser curvature is highly suspicious of malignancy. Diagnosis of gastric ulcer is not problematic at all, but the problem is to be certain whether this ulcer is malignant or not. Etiology not exactly known. Causes of gastritis precede ulceration are reflux of bile into the stomach, antral stasis, Helicobacter pylori, NSAIDs, and irritant substances. Reflux of bile into the stomach, it causes damage to the gastric mucosal barrier by the increasing hydrogen ions back diffuse, leading to mucosal damage. Antral stasis due to defective gastric emptying, hypergastrinemia. Helicobacter pylori produces gastritis, but its exact etiology is unknown. NSAIDs increases the risk of gastric ulcer, especially if with Helicobacter pylori. Irritant substances such as smoking, which inhibits ulcer healing, aspirin and alcohol. Pathology, gross appearance, size, larger than the duodenal ulcer, site at the junction of the body and the antrum on the lesser curvature. Some ulcers are saddle-shaped, overriding with lesser curvature. Edge and floor, sloping edges and floor covered by granulation tissue. Base, there's marked induration around it, usually lies in the muscular layer but may lie in any tissue. The ulcer has penetrated as the pancreas. Complications, acute and chronic. Acute, perforation and bleeding. If perforation occurs posteriorly, it occurs in the lesser sac. Chronic, penetration. Posterior ulcers penetrate the pancreas. High anterior ulcers penetrate the liver. Saddle-shaped ulcers penetrate both pancreas and the liver. Fibrosis, causing gastric outlet obstruction or hourglass stomach. Malignant transformation, rare, less than 1% of cases. Most malignant gastric ulcers are malignant from the start. You have to know that there are lineal ulcers in the gastric ulcers which lead to teapot stomach. Clinical picture, type of the patient, elderly, that appears thin and underweight, symptoms, pain, character, boring, location, deeply seated in the epigastrium, time, starts shortly or immediately after food intake, so the patients are afraid to eat, and this leads to loss of weight. Periodicity, less well marked than in duodenal ulcers, its loss may indicate malignancy, relieved by antacids, fasting, and vomiting. Nausea and vomiting. Vomiting relieves pain and may be self-induced. Clinical picture of the complications. Pain referred to the back, indicating penetration. Bleeding and perforation. Fibrous contractures. Hourglass stomach. Signs. Localized epigastric tenderness. Gastric ulcer pain doesn't occur when the stomach is empty. No night pain as in duodenal ulcer. Even if antacids fail to relieve the pain, the possibility of malignancy or penetration is present. Investigations. Endoscopy, barium meal, tests for Helicobacter pylori, Helicobacter pylori serology, breath test, culture from biopsy material, which is more commonly used. Endoscopy, the main investigation, directly visualizes the ulcer and its characteristics. Multiple biopsies, at least 4, obtained to exclude malignancy. Barium meal, second place after endoscopy. An ulcer niche, an outpouching on the lesser curvature or crater that remains filled with barium after its passage from the stomach, or ulcer notch, area of spastic muscle on the greater curvature, opposite to the ulcer niche. And finally, we have the treatment. Treatment, medical treatment and surgical treatment. Medical treatment, exactly similar to duodenal ulcer, but because of the risk of being malignant, we should and we must exclude malignancy before giving medications. PPIs and H2 receptors blockers, eradication of Helicobacter pylori, as you've mentioned in the duodenal ulcer. Surgical treatment, indications for surgery, failure of healing, starts at 6 weeks or to complete at 6 months after medical treatment, uncertainty about the absence of malignancy, complications of gastric ulcer which require surgery. Aim of the surgery for benign gastric ulcers to remove the ulcer or the entire ulcer-bearing area to ensure proper gastric emptying. Operation, partial gastrectomy, the standard procedure. It removes the ulcer together with the entire ulcer-bearing area, ended by gastroduodenal anastomosis, which is called Bellroth 1. Repeat endoscopy after 6 weeks, regardless of symptomatic improvement. If the ulcer shows no attempt at healing, considered malignant, and surgery is performed. Partial healing is seen, continue medical treatment for another 2 months, never exceed 6 months, and repeat endoscopy. If complete healing not achieved, surgical treatment. Some patients with gastric cancer may improve on the medical treatment. You have to know that complications of peptic ulcers are divided into acute and chronic. Acute perforation and bleeding, chronic fibrous contracture, pyloric stenosis and hourglass stomach, penetration, and malignant transformation. Perforation, pathology, depending on the degree of aggressiveness of the ulcer, will be rapid, slow. Rapid perforation leads to generalized peritonitis, slow, small, and rapidly sealed, occur more in anteriorly situated ulcers. Stages, chemical and bacterial. Chemical peritonitis at the time of perforation, duodenal or gastric contents are sterile, burst into the peritoneal cavity, leading to inflammatory response. Bacterial peritonitis, after few hours, swallowed bacteria with saliva and bacteria from the gut gain access to the peritoneal cavity through the perforation, turn chemical peritonitis into bacterial peritonitis. Clinical picture, symptoms and signs. Symptoms, sudden severe pain at the time of perforation, starting in the epigastrium and later becomes generalized. The patient usually collapses, especially with large perforation. Signs, general, tachycardia, rising pulse rate and pyrexia, abdominal examination, inspection, board-like rigidity, tenderness in the epigastric region. After few hours, generalized abdominal tenderness, rigidity, and distension. In some patients, the tenderness is marked in the right iliac fossa, wrongly diagnosed as acute appendicitis. Auscultation, we hear absent bowel sounds. The inflammatory exudate at first collects in the supracolic compartment of the peritoneal cavity. Soon spills to the infracolic compartment through the right paracolic gutter, left closed by the phrenicocholic ligament, and may remain localized to the right iliac fossa. So it's wrongly diagnosed as acute appendicitis. Small perforations may be sealed rapidly without much soiling of the peritoneal cavity. Differential diagnosis of perforation. Causes of acute upper abdominal pain such as acute cholecystitis, acute pancreatitis, mesenteric vascular occlusion, leaking aortic aneurysm, basal myocardial infarction, and from acute appendicitis if it presents by right iliac fossa pain. Investigations, urgent. Chest X-ray in erect position reveals air under the cupula of the diaphragm. Abdominal ultrasound reveals peritoneal fluid. Gastrograph in male. If perforation is suspected and plain X-ray failed to reveal gas under the diaphragm. Treatment, urgent operation after preparation. Aim of pre-operative preparation is to correct hypovolemia and electrolyte imbalance. If treatment is delayed, hypovolemic or septic shock will occur. In the case of perforated gastric ulcer, biopsy must be obtained. Pre-operative preparation include RILE, continuous aspiration, IV fluids are guided by urine output, electrolytes, and pH, IV antibiotics, IV PPIs, careful attention to respiration because it's often compromised. The operation, the simplest procedure is the best. Through peritoneal toilet, closure of the perforation with an omental patch, Graham's method, and the abdomen is closed with drainage. Post-operative medical treatment for the ulcer, and I'm sorry that I have to say this. Matary mentioned افتح اغسل درنا عالج. Bleeding, pathogenesis, hematemesis, and melena, occurs due to ulcer eroding a large vessel at its base. Small erosion bleeds a little, then sealed, may be repeated. Large erosion in the vessel wall leads to massive bleeding. Symptoms: hematemesis, vomiting, small dark brown, coffee ground blood. Melena, passage of loose, black tarry offensive stools. Bleeding per rectum. Fresh red blood may be passed with stools if bleeding is severe. Signs: in severe cases, hypovolemic shock, pale, cold, rapid pulse, low blood pressure. Investigation: CBC, hemoglobin and hematocrit value, useful only after few hours, leading to hemodilution. Treatment: conservative treatment, surgical treatment. Conservative treatment considered whenever possible. Stabilize the general conditions by admission to the hospital, better to ICU, high flow oxygen by mask, correction of hypovolemia by IV crystalloids and blood, monitoring urine output, pulse, blood pressure, and hematocrit value, and nasogastric tube. After stabilizing, IV PPIs, urgent endoscopy, done once the general conditions are stabilized. Findings may be seen, such as an ulcer with oozing artery, visible vessel in the ulcer base, or fresh blood clot covering the ulcer. Technique: fine instruments are introduced through the channel of the gastroscope, reaching the ulcer and arresting blood. Methods: laser coagulation, thermocoagulation, diathermic coagulation, injection of the ulcer base by adrenaline or alcohol. Surgical treatment: pre-operative preparation. The patient should have more than one IV line open and running. Nasogastric tube is passed. Stomach is washed and emptied. Indications: absolute indications and relative indications. Absolute indications: no improvement under adequate medical treatment. The initial bleeding was severe, 2,000 milliliters or more. Continuous bleeding that needs transfusing large volumes, 1,000 milliliters of blood per day to maintain stability. If bleeding recurs after endoscopic homeostasis. Relative indications: old atherosclerotic patients, because they cannot withstand the ill effects of shock and their arteries cannot retract enough to stop hemorrhage. Long history of ulcer disease, don't respond well to conservative treatment, and those with associated serious diseases. The risk of operation is less than the risk of shock. Operation: for gastric ulcer, gastrectomy, the standard operation. For duodenal ulcer, pyloroplasty and truncal vagotomy. Pyloroplasty: the pylorus is opened longitudinally to expose the bleeding ulcer. Homeostasis is achieved by underrunning sutures, and then it's closed transversely. Truncal vagotomy may be done or not to reduce acid secretion. Bleeding from a peptic ulcer always occurs, but only on microscopic level and considered part of the disease process. Small bleeds cause no alteration in general condition, and they require hospitalization and receive exactly the same diagnostic and treatment policies as large bleeds. Most of cases stop bleeding spontaneously due to clot formation in the base of the ulcer, obstructing the erosion in the artery. Cases which usually respond favorably to conservative treatment are young patients less than 45 years, minor bleeds, short history of dyspepsia, recent history of ulcerogenic drug intake. Drug withdrawal is all what's required. The decision to operate should be taken early, within 48 to 72 hours, as a result of late surgeries are poor with high mortality. And then we have to know about subacute perforation, that is small perforation. Only minimal amount of contents enters the peritoneal cavity and it's rapidly sealed. It gives the same early signs as acute perforation but much reduced. If diagnosed correctly, treatment would be conservative. Chronic perforation means penetration into adjacent structure as a pancreas, suspected when the pain becomes more or less persistent, and referred to the back. And this concludes our part for today for the stomach.